Yeah, there's a lot of things happening in bladder cancer. There continues to be a lot of trials in the BCG-unresponsive space that we are looking at, probably going to get some readouts in late 2025 from companies like J&J with the Pretzel, CG Oncology. All of this data is going to kind of add to where we are and add to the number of therapies we have in this space. You know, another really interesting space is the BCG-Naive space, where we're looking at combination therapy with immunotherapy plus BCG. We have 2 large trials with CREST and Potomac that are both going to read out in 2025, which will likely impact or influence a much bigger pool of patients, those patients that have never seen BCG but have had high-risk muscle-invasive bladder cancer. Yeah, we're still a little bit early in the bladder game with biomarkers, but there's obviously a lot of interest, and our experience with prostate is helping guide and operationalize a lot of practices towards doing this in bladder. Right now, we have FGFR, which is a marker that tends to be overexpressed in low-grade or intermediate-risk bladder cancer. That's a target, as we now have several FGFR-directed therapies in clinical trials towards low-grade disease. And in terms of other interesting things coming up out the woodworks, we do have AI that's really interesting. We're looking at pathology in a different way, trying to look at centralized pathology, understand the tumor microenvironment. There are companies in that space too. They're generating data that may help predict sensitivity to BCG, help predict recurrence and long-term outcomes. So genomics, AI continue to be a really big part of the future, but we're still not there yet. I would say the thing that's probably the most relevant today in terms of biomarker is ctDNA, which we are utilizing in the muscle-invasive and advanced situation when patients have had systemic therapy to try and monitor them for recurrence. And it now shows us that patients who are ctDNA positive perform and respond much differently than patients who are ctDNA negative. Yeah, I mean, again, BCG, has been the cornerstone of therapy for non-muscle invasive bladder cancer for a long, long time. And some of these BCG-naive trials are really going to be interesting to see if we are going to change that paradigm. Unlikely that every single patient in that space is going to be moved from BCG to an intensified treatment, but there's certainly a group of patients that may be. One of the biggest movements in bladder cancer, and this is more in advanced bladder cancer, has been the movement away from cisplatin-based chemotherapy and towards immunotherapy. And we are seeing that with EV302 and all of the metastatic space. We know that platinum-based chemotherapy is not the go-to now for medical oncologists, and that is down the road, I think, going to impact us in urologic oncology as well. Yeah, it's a really good question. Again, we know immunotherapy is really active in bladder cancer. Like I had mentioned, there are combination therapies in trial right now to see if BCG plus immunotherapy could be relevant. Immunotherapy by itself in non-muscle invasive bladder cancer has not proven to be a home run. There are probably some small subgroups that may benefit. Right now, there's not a great biomarker in bladder that can identify these patients very well. PD-L1 has been tested and looked at. It's not a clear-cut biomarker predictor of response. But I think what we're going to see is that there's going to be more and more of a role for immunotherapy in all of these states, whether it is combined with chemo, whether it is combined with BCG. I think we're understanding that immunotherapy is not going away. We're just trying to package it better to get the best possible response.